Hello everyone, hope everyone is well now. Okay, so today we're going to talk about hyperlipidemia. So the class will talk a little bit about the backgrounds of it, and then we'll go through about the different classes of drugs as usual, right? So cholesterol is the main topic about hyperlipidemia. So everyone says like, oh, I've got high cholesterol, so that refers to hyperlipidemia in the scientific way. But bear in mind, cholesterol is also a very important part of our human body. It's not just that it's bad, because you clog up your blood vessels and so on, but it's also a very important part to form your steroidal hormones, right? It's also a very important part of your cell membrane as well, and also from the bile salts and things like that. So because of that, there's actually self-synthesis of cholesterol in the body, not just from your diet. So synthesis of cholesterol is in the liver, of course. So bear in mind of that. So in terms of the drug modification and so on, so the main part that we can control is actually from the diet perspective. In terms of the synthesis of cholesterol in the body, we could reduce it slightly with drugs, but again, there's auto-regulation and things like that, which makes it not the best in a way sometimes, even though the person might have very strict dietary control. But if they are without medication, their cholesterol is still high because the liver just happily synthesizes more cholesterol. And just TG, which is your triglycerol, is also energy source in the adipose tissue as well. So bear in mind, these are all very important components because later on when we look at the reports and things like that, we always think that, oh, TG is not good, LDL is not good, but they actually play important roles in the physiological function of the body, right? As mentioned over here, triglyceride. Bear in mind there's different units as well. So this one is actually from the US unit, so they use mg per dl. Malaysia will mainly use the UK version, so you can see the numbers are much smaller. But again, details you'll see in the later few slides. So in a very simple terms, HDL is the good one, LDL is the bad one, TG is the bad one. So we try to reduce LDL and TG as much as possible, especially those with already have heart diseases. So we need to control that even further because clinical evidence already showed that if you control it well, it actually reduces the risk of total cardiovascular events. So it's something good that you should reduce. Right, so yes, mentioned over here the relative risk. So already different studies has shown, but there's also other newer studies as well, which again prove the importance of controlling the cholesterol level for individuals, right? But it's not as easy as it seems to be, right? So we'll go through later. So here is just to show you in the body, there are different forms of cholesterol literally, right? So you got the HDL, so you can see they're actually a little bit different, but there's a lot of similarity of course in between them. They can interchange, so you got HDL per se, you got LDL, you got VLDL, and you got your chylomicrons, right? So there's different size, right? Most of them are atherogenic, so meaning they are the not good ones, so they actually clog up the blood vessels. So you can see here the starting point is the liver. As mentioned, the liver will happily generate more of such. So the liver actually secretes in VLDL form, which then converts slowly and then eventually can get into HDL form, over here. And then it can be an intermediate form, right? And just bear in mind here that I like to highlight is that it's actually the LDL form, which actually goes back to the liver. So there's actually, and on the receptor part of it is actually the LDL receptors on the surface of the liver. So that's how they actually achieve the balance, how the body actually regulates the amount of LDL that needs to be produced, right? It's not the intermediate ones and all, it's actually based on LDL per se because there's LDL receptors. There's also HDL receptors as well, but it's not really used as a target, right? So the drugs mainly we try to modify this part of the pathway. So LDL is the large one and it's actually about 60 to 70% of the total body cholesterol. So again, it's actually back to the livers and 50% to all the cells, etc., etc. Right, so this is something to let you know, because before this I didn't really know about it until quite recently, I have to admit. And if you see all this print screen type of information, it's actually from the Malaysian guidelines, which is pretty recent in a way. It's in 2017, if I'm not wrong. So again, you are strongly encouraged, since you've got more time now, to actually read through the guidelines, because it tells you a lot more stories from there. Right. So actually, when you do a blood test, right, the levels that you actually do your biochemical analysis is actually, you can actually measure total cholesterol, HDL, and TG. So actually, the value of LDL is actually not measured directly, right? So it's actually through calculation that you actually get the value. You don't have to know the calculations, no worry, because normally, as any lab report, they actually just give you the full value, because it's like auto calculation. But just bear in mind, LDL values is actually through an indirect calculation, right? Okay, so and as mentioned just now, there's actually the genetic classification of dyslipidemia. So meaning, there's actually a lot of different types of genetic, if you can see here. There's familial, the more common ones is actually like familial combined hypercholesterolemia, hyperlipidemia. You can see the prevalence as well, right, under here. So this also reflects to you that if your parents have high cholesterol, it's actually a very high chance that you will have high cholesterol, right? No matter how strongly or how strictly you control your diet to nil lipid, but your liver is just too happy to produce more cholesterol. Example like myself. And also bear in mind, there's something that I learned as well, in a hard way. Like for some people, like me, during pregnancy, for some women, it actually tapers a lot. You actually shift the cholesterol synthesis as well. Like for this round, in the second round of pregnancy, my cholesterol level is actually sky high, super sky high. But because a lot of drugs that we use cannot be used, like statins that we're going to talk about later, it's actually contraindicated during pregnancy. So basically, I just have to wait for the pregnancy to end and see how bad is it currently. It will drop down actually, but yeah, but this one was sky high. The previous one was high, but this is sky high. Just FYI, so this is something that to bear in mind, that a lot of drugs are not indicated during pregnancy. Right, so there's also secondary causes of dyslipidemia. So again, some are lifestyle indicated, like smoking, physical inactivity. So you can see a lot of times it actually influences the triglyceride. So the common ones in the way is probably, as mentioned, the alcohols, and also the type 2 diabetes. Obviously, Malaysia is very good in a lot of high statistics of the bad ones, like type 2 diabetes. So you can see it can actually increase cholesterol and TG. So again, all this has an interplay role. So sometimes it's easy to find people with diabetes, hypertension, and dyslipidemia together because they inter-influence each other. But in this case, it's more like dyslipidemia. The diabetes influence the cholesterol production. And here also there's some information about end-stage renal failure and also drugs per se. So as mentioned, if the person is on drugs like beta blockers and things like that, which is very commonly used for diuretics, commonly used for hypertension, so it also influences the cholesterol values as well. So the middle one was, I can't go back, the TG levels. So again, when TG goes up, your LDL goes up as well. So bear in mind, all these things comes together. So there's also secondary causes, as mentioned just now. So this is to show in the table form. So there's also different drugs which can cause it. So like estrogen replacement therapy or combined oral contraceptive, some of the antihypertensive drugs. So yeah, if they start to have like hyperlipidemia, you may want to change the drug. It depends on the individual. Or some of the books actually say that if you use beta blockers and things, it tend to unmask the hypercholesterolemia. So maybe it's an underlying one, but it just didn't show it very clearly before this. Right, so and there's a few others as well. Right, so similar like a lot of cardiovascular diseases, it's actually divided based on the risk. So like your hypertension as well, there's also risk. So and this would determine how strict your control should be, right? So similar for cholesterol, people already develop certain stratifications as well. So again, you have to check where the individual is falling into. So as mentioned earlier on, please read through the guidelines. It will be very, very helpful for your case studies later. There are some examples of case studies that I'm giving you as well. So hopefully you have time, you go through them. They'll serve as a guide for your actual case study as well. Right? So yep, remember a lot of things will be open book now. So we assume that you have information and you have access to all this information, right? Where you can find them and find out the answers for your case. Right, so it depends on the risk. So you know how strong you should control your LDL levels, like for here. So if there's nothing wrong with them, then obviously it's low risk. So if they have a lot of issues, as an example, like high risk or very high risk, as you can see, if they already have diabetes with proteinuria and things like that, which is really a little bit of multi-organ damage in a way, your LDL levels is actually, the targeted LDL level is really low. Like this one is less than 1.8, right, the cutoff, right? So these are the ones that you should bear in mind. Whereas the others, the level will be about 3. So you can see it's about nearly half, right? So it's a very strict LDL level that you're trying to get. So as mentioned earlier on, a lot of it is based on this particular guideline. So it's 2017. Pretty recent, not bad, quite a nice read. Strongly recommend to read it. Okay, so you don't have to memorize it, but it's good to know what is information and where is it, so you can find the information out much quicker. Right, so pharmacotherapy, as you can see here, this is to show you the importance and the commonly used drugs in a way. So statins, as you can see, appears almost everywhere. So this is the very important drug. So by hook or by crook, most of the time you see statins. Right, so and statins can be combined with other drugs as well. So, and bear in mind there's also this asterisk with after therapeutic lifestyle changes, which include your smoking cessation, your dietary, etc., etc. I didn't put a table down over here. Again, it's in the guidelines, so just because it's just way too long, just read through over there as well. Right, so you got your Ezetimibe, your fibrates, and PCSK9 inhibitors. Right, so this is from another guideline in a way. Again, just shows you when to use what drug. So bear in mind that for statin itself is quite interesting because there's actually a few examples. Later we'll go through them. And they're actually divided based on their intensity of treatment. So there's the highest intensity is actually rosuvastatin and atorvastatin, right? So that's the highest one. So meaning if the person's at very high risk or a very high cholesterol level, these are the two options that you could use. Not to say the others are useless, but these two are the higher intensity ones. So in a way, it also reflects that probably the side effect profile may be stronger in a way. Right, so if they are not, it's not very effective, then you can top up with different drugs. Right, so again, it's similar like hypertension in the way that the first drug doesn't use, then you might combine, etc. But although, of course, hypertension, there's new saying that you can actually start with 2 drugs if it's very high. So it's good to know when to use what. So let's go through the famous statin. How does it work? Right, so statin itself is actually from something pretty natural. Later we'll go through it again. So it's actually from the red yeast rice as well. Later we'll go through. So statins itself per se, how does it work? It's actually a competitive HMG-CoA reductase inhibitor. Right, so it's an inhibitor for HMG-CoA reductase, so which happens at this part of the pathway. I don't really need you to remember all the thingy-wingy names around here, but you need to know that HMG-CoA is one of the very important paths which eventually leads to the formation of cholesterol. So if you have a lower inhibit the enzyme or the enzyme that produces it, so eventually cause a reduce in the production of cholesterol. So reduction in the production of the cholesterol would then somehow would then cause lesser of this sterol, right? Because our body's response will actually cause an upregulation of LDL receptors, right? So when it's upregulated, so there's more LDL receptor expression, which actually eventually causes more LDL reuptake back into the liver. You get it? So remember just now in the second slide, which actually shows that there's LDL receptors in the liver. This is what it means. So the LDL receptors helps to take, basically like recycling, like take the LDL back from the blood into the liver. So in a way, you actually cause an even further reduced in the LDL level, i.e. the plasma LDL level, which is circulating around in the body. Because remember, for the cholesterol to be bad in a way, inverted commas, right? So it would have to be deposited in your blood vessel wall, so that it forms the atherosclerotic plaque. So i.e. it has to be in the circulation to be able to do that. If it's in the liver, you can't do that, right? So therefore, our aim is actually basically just shifting in a way the LDL from the circulation back to the liver. And obviously we try to reduce its production per se as well, right? So this is how the wonders of statin. Right, so as mentioned just now, there's high intensity, moderate, and low intensity. So just bear in mind the first drug in a way that it was Simvastatin is the one that's being first in the class. And Simvastatin, actually the first trial, I can't remember the paper, it was the very famous one, which actually shows a reduction in the cases and also an improvement, meaning a lesser mortality rate for CVD, for cardiovascular disease patients. So therefore it becomes such an important drug. So after that, all the DLL drugs are also, etc., are also being developed. So as mentioned just now, the high intensity one is the Atovas and Rosuvastatin, so Lipitor and Crestor, selling like hotcakes. But if you go for the clinics in the government, it's mainly at Simvastatin. Right. So pretty few quite some side effects, common side effects. So bear in mind, some of it are actually the muscle related ones somehow. It actually causes myopathy and rhabdomyolysis. The others are the standard ones in a way that you obviously have to monitor, like hepatotoxicity, diabetes, So you can see diabetes is here as well. So as I say, the drugs will interrelate to one another. Right, so again, there's some other more common ones are like GI disturbance and things like that. Obviously, the others more severe one are less common. So, but bear in mind, this is one of the rare drugs which can famously causes myopathy. So there's also some guidelines which shows how we should monitor myopathy actually. So myopathy in a way is actually causes problems like painfulness and weakness of the muscles. So and this is actually quite high. If you look at the liver dysfunction, you look at the second paragraph here, it actually happens up to 10% of them. Right, so but it's still tricky in a way that sometimes muscle pain can occur to anyone. So whether they have statin or not statin, so they actually have to monitor and just rule out properly whether it is it a pain caused by the statin or not. Right, so there's obviously some risk factors, obviously. So if they already have pre-existing muscle issues, if they have kidney or renal disease and things like that, and again, high dose statin treatment. So again, higher dose, again, has higher risk of side effects. Right, so but we don't really need to monitor the liver very routinely, right, unless they already have some issues. Right, unless they already have issues like ALT is more than 3 times and things like that. So sometimes if there's issues, then obviously you have to reduce the dose of statin or just stop the statin. Right, so again, for muscle pain, you may need to reduce it or just stop it, just to see whether it gets better or not for the muscle pain issue. So another thing about red yeast rice. Okay, so red yeast rice is interesting because it's a very common supplement in a way that people use to recommend if someone has hyperlipidemia, because it actually contains lovastatin, right? So and several other forms, which actually is the naturally occurring form of statin. So meaning, in case you have someone who has high cholesterol, but the person has not been started with statins yet, so the person might and could go for red yeast rice supplements, right, because it actually contains statin. You actually have to view it like a baby statin, right? But the thing is, if the person is already being on statin and coming to you to say that may I get some supplements maybe to further reduce my cholesterol level, you should not in a way recommend red yeast rice, because it will be like statin plus statin again, so there'll be higher risk of adverse effects. So I have to be a bit more careful about it, right? Because basically it's like a baby statin. So that's about the statin story. So let's move on. So another popular drug that we look at is called Ezetimibe. So this one is actually working at the intestinal part, on the absorption of cholesterol. So when you look at it, it's actually here, Ezetimibe here. So in the absorption of cholesterol in the GI tract actually requires this NPC1L1, right? So this is actually a channel, right? So which actually causes absorption of the lipid into the system. So basically when you inhibit it, so it'll be lesser uptake or lesser absorption. So therefore, in a way, what are you thinking? How is it gonna influence the liver part, right? Because this one, the mechanism is mainly on the GI. So when there's less cholesterol absorption, so there'll be less LDL in the body, in the plasma, or in the body. So again, our body will think that, hey, probably we need more, right, in the liver. So therefore, you might have, we'll try to get a little bit more from the overall system. So there'll be increase in LDL receptors in the liver for short term. However, as mentioned before, so our body is too clever, it will compensate for it. Since there's less cholesterol, we don't have enough. Remember, cholesterol is also an important part of the body. So we can increase the synthesis anyway. So therefore, Ezetimibe will be a very useful drug if you actually use in combination with statin, whereby statin can reduce or inhibit the compensation increase of synthesis of the cholesterol. So it's good to combine both, because then it reduces the compensation effect of Ezetimibe, right? So Ezetimibe is also a drug which undergoes quite heavy enterohepatic recirculation. So you just have to bear in mind. So there's not that much significant drug interaction, only with cyclosporine. So it has strong interaction with it. So it actually causes increase in the cyclosporine concentration. So but anyway, cyclosporine is a very rare drug to be used. But if there's if the patient is on both, on cyclosporine and then to top up with Ezetimibe, you have to be careful, because it can easily push the cyclosporine concentration to a very high to toxicity level. So you just have to monitor and then modify and reduce the dose of cyclosporine. Go find out how it can cause the interaction of mechanism if you're interested. Right, so another part is about fibrates. Fibrates, there are two main drugs in this family, which is the Gemfibrozil and finofibrate. So again, this is mainly on the lipid metabolism. And it's actually multi-effects if you look at the chart. So basically, these two drugs, or fibrate drugs in general, actually cause the activation of the PPAR alpha. So it's actually a transcription factor. So when you influence the transcription factors, you can see the effects. It will influence the effects of multiple genes. So overall, it actually causes all this synthesis, as you can read through the details over here. So eventually, it can cause an increase in HDL and a decrease in TG. So that's why you can see here, fibrates is a bit interesting, because it actually reduces TG more specifically compared to statin and also the Ezetimibe that we looked at just now, right? So fibrates is more specific towards TG, and it also increases HDL. So again, common side effects are like GI discomfort, but it also increases the risk of, there's also drug interaction with warfarin. So again, bear in mind, because all these are cardio drugs, so you could face a case that patients are on these drugs. And there's also increased risk of gallstones, especially for Gemfibrozil, and also increased risk of myopathy. So if the patient actually had a very high dose of statin, then you have to be careful in case there's myopathy or muscle pain that occurs when you top up with a fibrate. Let's see. Alright, so cholestyramine and cholestyramine is the OO drug of it. and it's happily available as powder. So obviously no one likes to use powder as a drug because it's very leche, it's very troublesome in terms of the compliance. And it's not just about compliance, but it's also about the dosing as well, and how you're going to scoop it at a correct dose. And there's a lot of GI constipation and bloating, because remember there's a lot of lipid being discharged out of the body. So obviously it's like, i.e. that you eat a lot of fatty food but you cannot digest them, so it has to go out. So there's a lot of bloating. It's not very pleasant feeling actually. So and because it interacts with food in a way, so you have to try to space it out as well, because you mainly want it to target the bile acid. If not, you bind with the food and a lot of other things with the food, because it's a positive negative charge. You don't know what else is positive negative, whatever is negative charge in your food as well. So you have to space it out with the food. However, there's this colesevam, which is great because the other newer ones are in tablet form, and it showed that it can reduce LDL pretty well, right? But somehow it actually contraindicated for people with very high TG per se. So why is it so popular suddenly? Because there's newer studies which shows that somehow you can actually combine colesevam with the type 2 diabetic drugs like sulfonylurea and so on. So it actually causes a better control of the diabetic per se as well. Right, so we don't really know why, but because they only suggest that maybe it also activates the other receptors, right, indirectly, right. So therefore, just bear in mind, bile acid per se has its own receptors, right? So it can activate all these receptors indirectly. So because of this newer study, so that's why it's not like if the person don't have type 2 diabetic, you add on a type 2 diabetic drug to them. No, but it's very common that people with diabetic has hyperlipidaemia as well. So you can top up with colesevam. It seems to give a better benefit compared to other cholesterol drugs. Okay, right. Another one, which is if you're in the community, you probably get more questions about it, is about your omega-3 supplements, right? So another way that we try to improve LDL in the body is we give the body enough good cholesterol in a way from the diet. But this is to bear in mind there's actually different classes of oil, different classes based on the percentage of omega-3. So again, the percentage of it will again determine the efficacy, and also determine the price tag that it has. Right, so you've got the retail ones, and bear in mind, you can see some people might, after getting the fish oil, they may come back to you and say, hello, it's not really useful after I taking it for 3 months or 6 months. Because, again, it depends on the dose of omega. Even if you use the very high way of distillation, etc., and processing and extraction, even you get pharmaceutical grade fish oil, you actually need 3 to 4 pills a day, which is quite a lot, considering its price tag as well. So imagine if you're just getting the normal one, which is a much cheaper one, you actually need 12 pills a day. That's a lot of oily stuff. So so these are the ones. So the omega-3 IE is actually a combination of the EPA and DHA, right? So the EPA and DHA. So make sure when you get your omega, you get your supplements, make sure you just check the level of EPA and DHA, right? So because they say 1 gram will contain at least how many grams mg of the free fatty acids, right? So you can see one, as you say, you look at this one, it's actually one of the trials that they did. So what happens is that 1 gram is per capsule, so you need to take 4 in a day. Actually, it can effectively reduces your TG. So you can see the fish oil value or omega-3 mainly targets TG and VLDL, right? So these are the two main targets. This doesn't really affect the LDL that much, right? So it's towards here. So it's particularly good in a way for people with high TG. So yep. So this one is we're trying to dig out why and how it can actually reduces TG. So there's a lot of suggestions, as you can see here. This is from one of the papers. So because no one really know exactly what's happened. So you can see that it can somehow, the main one that they suggest it actually is it inhibits this enzyme, right? So but then therefore this enzyme is part of the whole pathway, so therefore it reduces the production of TG eventually, In a very short version, that's the explanation. Right, so another part of it, this one is a drug which is really, really old. I don't think you see it much, but just because it's still in some old textbooks, I just mentioned very briefly. It's called Niacin. Niacin is actually also vitamin B3, right? But the thing is, you need an ultra high dose. So this is a drug which is used to control for cholesterol treatment before we have a lot of the other options, the newer options that we mentioned just now. So this is one of the ways that we can use. You can see again, so basically it has its own receptor. It's got its own niacin receptors. It's vitamin B3. Again, you have to look at the dose. It's a giant dose. It's in grams again. So so somehow it reduces the free fatty acids. It reduces it decreases the synthesis, and overall it also reduces the clearance and increases the removal. Right. So overall, it can reduces LDL and TG. It's not great because it has this annoying, it's not life-threatening, but just pure annoying flushing side effects up to 80% of the people. So it's really, really high. So that's why it's not favorable. It can also cause itching, especially the first few weeks. So you can easily treat it with NSAIDs, right? But then again, it's another annoying one since we've got better options now, and there's other drugs in a way. It's not just better side effects, but it's also better effects. So it can also cause hyperuricemia, so it may cause gout in some people as well. It may cause diabetic in some people as well. So that's why it's not favorable. Right, so we go to the new one, alirocumab. So based on the guideline, like the 2017, the Malaysian one is not really available in Malaysia formulary yet. Right, so this the development of alirocumab, I think it actually shows how desperate people are actually in terms of I want to reduce my cholesterol level. Why do I say that? Because when I initially see that, I got shocked as well, because people are so determined that I'm willing to actually use an injection to reduce my cholesterol. I think that's a different step altogether, because from the name, MAB is a monoclonal antibody, right? So it's not really available in tablet form. So this is actually a PCSK9 inhibitor. So there's two drugs in the market. So one is alirocumab, another one you can see in another slide. So it's the same target. So it's towards this PCSK9, right? So you can see here, basically it just increases the LDL receptors, right? So basically, this without the inhibition, it after the LDL receptor binds to an LDL, it will actually bring down to its degradation. So this one will prevent it from being degraded, from the LDL receptor from being degraded, preventing its internalization and degradation of the receptors. So therefore, there'll be more receptors on the surface, they'll stay longer, so there'll again be continuously more uptake of the LDL into the liver. So therefore causes a reduction in your plasma LDL level. Sorry, it's overlapping, but so basically the full name of PCSK9 is this proprotein convertase subtyrosine kinase type 9 receptor. Okay, right, and it's an inhibitor in this case. So if you want very nice videos and things in terms of the mechanism, you can easily go to their website links as mentioned here, which actually shows you an animated form of this mechanism. So hopefully it might be easier for you to remember. So it's actually used for people with very high risk of cardiovascular risk, very, very high risk. Those people which are not controlled with statin and all the other things, this is something you can try. So yep, you can be in a pen, given as 2 weekly subcutaneous injection. So there's another one, evolocumab, which is also a PCSK9 inhibitor. This is a monthly injection, right? So yep, preventing is so the wording explanation is over here as well. So in terms of its MOA, so it can be used in adjacent to diet. So there's also another diagram over here which shows how it works. So again, if you have the inhibitor, so you prevent it from coming in to be degraded. So it comes in, it goes out again. So overall, there's increase in the total amount of LDL receptors on the surface. Right, so that's about it for the statins and the cholesterol topic. So there's some summary of the drugs, so hopefully it helps. And there's also some monitoring for different drugs, so some are some side effects and interaction that you can find over here. There's also a case over here. I don't have the answer as well, so but you can have a look through of it. So because the case studies you will get will be pretty similar to all this. Okay, have fun reading. See ya. Ta.